Good day and welcome. I'm with Mr. ASHOKE Roy, who's the lead urologist at Royal Free Hospital, and he's also the NCL Cancer Alliance Urology Clinical Network Director. Good day, ASHOKE.
Good day, really. How are you?
I'm good to see you.
Thanks.
And as part of the Prostate Healthcare Call to Action Roadshow, Ash is really going to speak to us today around quality of life, consultation, the diagnosis, the treatment, and some of the cultural issues. And we're really pleased because in this dialogue, you're really going to understand what happens once a man comes into the care pathway. And so a lot of this information will be of great interest to friends and families as well. But over to you, Ash.
Thanks for the introduction. So just to clarify, I'm a urology surgeon, but I predominantly work in prostate health, prostate cancer diagnostics, and I work at the Royal Free, but also have aspects of kind of care across the whole of the region when it comes to looking and managing prostate cancer patients, as part of my kind of role with the Cancer Alliance. So the focus of our efforts is to try and improve cancer care, specifically prostate cancer care for men across North Central London, including Haringey, of course, and you know, your community will no doubt have quite close links with a lot of the hospitals that fall within our patch. Certainly University College Hospital, the Whittington Hospital, Chase Farm, North Middlesex, etc. So we know that all of those sites do prostate cancer diagnostics. It's very likely that if you are diagnosed or being referred for a possible prostate cancer diagnosis, that you're gonna see one of us, and we're gonna look after you. And I think if I can reassure you of nothing else, then that's the thing to take away. Prostate cancer is really common. I'm sure you know that. 1 in 8 men in the UK will get prostate cancer at some point in their lives. And we know that black men have a higher risk of prostate cancer, almost double. So 1 in 4 men of African and African Caribbean ethnicity will have prostate cancer. Again, that risk is even greater if you've got a family member who's had prostate cancer, particularly a first degree relative. So we mean your brother or your father. But also we think a family history of breast cancer in a female relative is also something that might increase your chances. So that's something to be aware of in the community. We also know that prostate cancer in itself doesn't necessarily have any symptoms. It's a difficult one to pick up, and sometimes you just have to base it on what your risks are as an individual, and whether you feel that you need to get tested. And I would encourage any black man sort of over the age of 45, especially if you've got a family history, as I've described, of prostate cancer or breast cancer, to get yourself tested, get to see your GP, have a prostate blood test. It's just a blood test. You don't need to have a rectal examination or an internal or anything like that at the outset. Have the blood test, have a conversation with your GP about what your risks are as an individual and where we go from there. And that's where we come in the system, in the kind of hospital setting. Once your GP's made that referral to us, we'll see you within a fortnight generally. That first review with us will either be a telephone call with a specialist or a face-to-face review with a specialist in the clinic, whatever kind of is convenient and whatever works. We'll usually organise some tests as well. The best test that we can do to see whether there's cancer in the prostate or not is something called an MRI scan, which is a big magnet, a magnetic resonance scan. Doesn't need any x-rays or anything else like that. There is an injection of some dye which helps, but you don't have to have it if you don't want it. It does help in terms of getting a better image quality, but we can get enough information without it if you don't want the dye injection. The scan takes a while, takes about 40 minutes or so, and it's relatively confined, the space that you go into for the scan. And it's quite loud as well, so something to be aware of when you're having the MRI, but it is really important. Things that can sort of stop you having an MRI scan: if you've got a heart pacemaker, or you've got a bit of metal in your body somewhere, certainly metal fragments in your eyes. We sometimes get if you've got a background in welding, or if you've had a shrapnel injury or something like that. They might need to just do some other tests just to make sure it's safe for you to have an MRI scan. But the majority of chaps are absolutely fine. We get some really high quality, detailed pictures of the prostate gland, and that helps us to work out what's going on. And we put that all together when we talk to you, not just about your ethnicity, your family history, your individual risks of prostate cancer, but also what the MRI scan shows, what the prostate blood test level is, and we put all that together to work out what your sort of defined individual risk of prostate cancer disease is. And we know by doing an MRI scan that we can exclude or rule out prostate cancer in around about 20% of men. The reason being is that we know that the PSA blood test, the prostate specific antigen blood test, it's not that great. It's the best test we have, but it's not a brilliant test. What it allows us to do is to identify a problem with your prostate, but it doesn't tell us what that problem is. And that's where the MRI scan comes in. We know that your PSA level can go up and down for lots of different reasons, the same way your blood pressure can go up and down for lots of different reasons. If you've done a lot of vigorous exercise, if you've had sex before the blood test, if you've had an internal examination, all of these things can push up the PSA level, but your prostate cancer risk can do that as well. And that's kind of where you end up in our services. The PSA itself, or the prostate itself, has a function in terms of producing a lot of the fluid that comes out when you come. That fluid is a little bit of sperm, but mostly prostate fluid in your ejaculate. And that's what your prostate does. It also supports the bladder. It supports the sphincter muscles that stop you wetting yourself. It supports the nerves that go around the prostate to give you your erections. And that's why prostate health is so tied up with urinary health, with sexual function, and that has a bearing on treatment going forwards. But taking it one step at a time, that's where we that's why prostate cancer becomes quite an emotive thing, because it's not only an organ that affects your your life in terms of whether it has cancer or not, but also the treatment for that can then have an impact on your functional abilities, your ability to get an erection, your ability to hold on to your urine. And these are all really important considerations that we take into account when we're talking about the diagnostics and where we go from there. And these questions kind of play in right from the get-go, because you might sort of be challenged at times when you sort of say, if you've taken the trouble to say, I really want a PSA test, I really want to know what my prostate risk is, and certain health professionals may say, no, it's not worth it, don't do it. The reason is because it's twofold, really. The first is there's a sort of a sense that this might end up being a bit of a Pandora's box. We open up this PSA blood test, and we then have to work on what we're going to do about the results. I don't think that should be a reason to not have a test. I think it's a reasonable thing to have a sensible discussion with your healthcare professional, your GP, and your family and your friends and your colleagues and people that you know and love that will have an influence on you and your care. I think it's worth getting checked, and I'd advise certainly all black men with a family history, but all black men over the age of 45 need to be aware of their prostate risk, need to be able to access that. And that's what we're here to provide. I think though, the reasons that some people may be steered away from a prostate blood test or steered away from going down the line of investigating their prostate is that we do know that treatments for prostate cancer can have an impact on your quality of life and your functional status, on your ability to do the things that you feel you need to do in your community, as in your family, as a man. And we also know that although a lot of people are diagnosed with prostate cancer, and yes, the risk of more aggressive prostate cancer in younger Black men is significantly higher compared to the Caucasian white population. We know that prostate cancer treatments work best if you're likely to live for another 10 years, because the rate or risk of prostate cancer progressing over a 10-year period is relatively low. It does progress, and in more aggressive cases, it will do so more quickly. But in the kind of common or garden, low, medium risk prostate cancer, it may not do anything immediately. And if you've got another or a lot of other medical problems, if you've got significant heart disease or kidney disease, or you're likely to suffer with other health problems, then I guess adding to that kind of complexity, if it's not going to do you any benefit in terms of finding and going through the diagnostics, isn't going to be the best thing to do. It doesn't mean that you shouldn't be tested, and it doesn't mean that you shouldn't have that conversation. But I think if anyone's going to deny you a test, they have to have a good reason for it, because you have a right to know, and you have a right to have a PSA test. But what we do thereafter is a more complex and more subtle discussion about you as an individual, your other medical problems, and what the impact that could be on your other treatments, but also you as an individual. I feel like I've strayed away from where we're going in secondary care, but
important information though.
Important information, I think, and it's worth knowing that they're none of this is kind of cut and dry. There's a lot of conversation. There's a lot of subtlety. There's a lot of a lot of variability to the kind of discussions that you're going to have with people. Everything has to kind of be based on you as an individual, and that's the focus that we would have. Talking to the man in front of you with the information that we have. So it's really key that if you do get into the system, if we do come into the system, you do come into our services, we are talking about your prostate risk, your prostate health, that we go on to have the MRI scan, we get as much information as we can. And then with that information, we can then talk to you about what are the next steps, what are we going to do next, how are we going to make this better for you. All right.
So at this point then, Ash, what would you say the individual and their families can do for themselves from a self-care,
Sure.
and of course, to some extent, self-management? Now that they are in the system, they may be on some kind of medication. Could you give us some advice around those two areas, the self-care, self-management, or three
Sure.
areas, and the family support?
So I think family support is really key. I think not just in terms of prostate health, but general health and mental health, I think, is really important. As a guy, you can feel like you're getting at this on your own. You've got to be there for your family, to be the supporter, the breadwinner, the guy that kind of is supporting everyone, and that you can't afford to be ill and you don't have any symptoms, so I've just got to get on with things. And I think we underestimate our families at our peril. I think there's a lot of understanding there from our spouses, our partners, our family, our children. People understand that you you need to look after your health. You need to be switched on and engaged with this process. It's important so that you can continue to be the kind of pillar of support that you need to be, or that you feel you need to be for your family. And you know, being that kind of person is it's quite a lonely place to be. And I think if you don't open up to the fact that there are people that love you and people that want to support you, not just in your family, in your community, your friends, that want to kind of get you through, and we want to do the same, then I think that's really key to getting you through the process, because it can be kind of arduous, certainly going through the diagnostics, but also the the treatment as well. In terms of self-management, there's a lot of myths and things out there about, well, certainly people might say, well, look, I don't have any symptoms relating to my prostate, so I don't need to get checked. There's nothing wrong with me. Again, being aware of the risk that is inherent in the kind of Black community, especially if you've got a family history, talking to your relatives about, what their experiences were, talk to your fathers, talk to your brothers, talk to your grandparents, what happened to you? Were you diagnosed with prostate cancer? You need to know, for your own risk, for your kids' risks, what runs in your family, not just prostate cancer, heart disease, diabetes, kidney problems, all of it. You need to be open and be talking about it. If you're not talking about it, you're living in ignorance. And if you're living in ignorance, you're just going to blindly walk into something and it's going to hit you for six. I think, forewarned is forearmed, sorry. So the more you know about your family, the more you know about diseases and problems that run in your family, the better it's going to be for you.
Okay.
We know that prostate cancer will only give you symptoms if it presses on the water pipe or if it goes into the bladder. The way I talk to chaps about their prostate is, I describe it, it's a bit like an orange with a straw shoved through the middle of it. Now that straw is where you pass your water through. Now the middle, the flesh of the orange, is what's in direct contact with that straw. So if the flesh gets bigger, if you've got what we call BPH, benign prostatic hypertrophy or hyperplasia, sorry, the enlargement of the prostate, which a lot of men get, King Charles has been treated for, that benign enlargement is what gives men waterwork symptoms. But cancer happens in the peel of the orange. So it happens on the outside. So there's not necessarily any contact with the water pipe. You're not necessarily going to get symptoms. The PSA test tends to reflect a growth within the central part of the prostate gland, but also is released by the cancer as well. So again, the PSA test highlights a problem with the prostate. Prostate symptoms, urinary symptoms, highlight a problem with the prostate, but it's not necessarily prostate cancer. But it means that we need to check you out. It means we need to have those conversations. It means we need to do the right tests to get you through and sorted as soon as possible. The majority of chaps that come through our doors, I'm delighted to say, we can reassure that they don't have prostate cancer. That's the best day ever. Your tests are all clear. So don't hide away from it in case things happen. We need to know, and you need to know, and that way we can get you treated effectively and as efficiently as possible. In terms of what you can do to make things better, there's a lot of things about the diet that might help: lycopene, which is in tomatoes, selenium in Brazil nuts, vitamin E in sort of leafy vegetables and things like that. There's no real evidence to say any of those things are particularly beneficial, but as part of a healthy, balanced diet, they're always worth doing. We know that if you're really overweight, if you're obese, or if you're a smoker, there is a higher risk of more aggressive prostate cancer. But whether that has an impact on your overall risk, we don't really know. There's a lot of unknowns and uncertainty over what exactly stratifies your risk for prostate cancer. But the thing that does cause prostate cancer is living longer. So the older you are, the more likely you are to get prostate cancer. It's almost like in certain circumstances, it's a disease that you get. If we all live to 120, we would all die of prostate cancer. That's the way we're all built. But if eventually something gets us first, people don't live that long. Certainly men don't. But if the older you are, if you like, the higher the risk of finding prostate cancer. But then, as I was saying earlier, there's also a higher risk of you having other medical problems, of your life expectancy being curtailed because of heart disease or diabetes or kidney failure or something else that is way more significant than prostate cancer in that age group. So that's where the kind of nuanced conversation comes in as to what we need to do and how we need to investigate this further. But that's a conversation that you can only really have in great detail with your specialist, with your consultants, with your nurse specialists, with your GP, but with the support of your family, with the understanding of your community, and the proviso that you take it seriously, and you kind of go through with what you need to have done.
Excellent, excellent. So Ash, give us your final thoughts. So what's the final message that you would?
So I think, we've talked a lot about prostate cancer risk, and we've talked about getting into the system. I suppose what I haven't really covered is what actually happens to you when you're in the system. You have your MRI scan. If there's a concern on the MRI scan, we would generally recommend a prostate biopsy. I'm not going to lie, a prostate biopsy is an invasive test. It requires an ultrasound probe being put into your bottom, and we take sort of very fine needle cores of prostate tissue, usually through the skin, occasionally through the back passage. There are risks with any invasive procedure, but I think the key thing to tell everyone is that, number one, a biopsy does not cause cancer. If you have prostate cancer, a biopsy doesn't cause it to spread. So those are absolute facts. There is no evidence whatsoever that a biopsy will make anything worse for you. There are the side effects of a procedure. The water flow might slow, the erections might get a bit weaker whilst that swelling settles, but those are all very temporary and transient as you recover from the biopsy procedure. The same as if you were having, I don't know, a skin biopsy or another procedure somewhere else. There's always risks and side effects that are short-term and self-limiting, but it's really important that you engage with the process, that you have the diagnostics that we need to do to really establish your risk. And in terms of treatment, look, treatment for prostate cancer, as I said, works the best if you're, in terms of keeping you alive, if you're going to live for longer than 10 years. And we know that if we catch prostate cancer early, in its early stages, when it's confined to the prostate gland, the cure is excellent. You'll have a normal expectancy of living your days out for as you would. I put that in the backwards way. You would have a normal life expectancy compared to if you didn't have prostate cancer. So if we catch it early, and that's why it's really important to get tested, it's not going to affect your life in terms of how long you're going to live. There are conversations and things to be talked about with regards to the side effects of treatment. And more men are going on to what we call active surveillance, which is a process of disease monitoring. We know now with MRI scans and PSA blood tests and biopsies, if we need them, that we've got really good ways of monitoring prostate cancer. So we can see when it's going to go from being perhaps a low risk disease to being a bit more aggressive, when we might need to be more encouraging of having a treatment. That treatment could be an operation to remove the gland. It could be radiation treatment. Both of those options have issues, have side effects, but both of them are really good at curing you. So it's that conversation about what are the trade-offs, what are the trade-offs between curing prostate cancer? What are the potential side effects that you might suffer? Obviously, there are risks, but those risks will vary depending on you as an individual. We're really here to have those conversations, to understand what matters to you as an individual and how we can incorporate those concerns and those ideas and those expectations with what treatment is needed, so that we can make sure we're giving you the right kind of advice, the right kind of treatment, and we can get you back to your families and back to being the pillar of support that you know you are.
Thank you very much, Ash, and that has been most informative. And please take care. Thank you.
Thanks, really.